Well, thank you for having me. My background is in medicine. I'm a physician and actually for many years practiced pulmonary medicine, critical care medicine, and sort of wandered into this field. It turns out this is a very big field, growing field, I think lucrative field for those who are in big data, and I'm going to do the best I can to describe what it's about. So, as common in healthcare presentations, we have to disclose. I don't have any disclosures to mention at all. And of course, you always have to start with a quote. Without data, you're just another person with an opinion. Certainly, this seems to be an issue we have today. So, I'm going to talk a little bit about what I'm going to talk about. So, one, I'm going to talk about the healthcare landscape, and this is important because the healthcare landscape shapes what we are doing now in data and big data analysis. I'm going to try to address some of the data sources, the characteristics of the data and the type of healthcare data that you may be faced with in this area. Look at a couple published studies using big data, some really interesting things now making it into the medical press, and also review a few concerns and caveats about the use of big data in healthcare. So I always start with the healthcare landscape. I mean, everyone has a sense of what it's about in the United States. One, we know, and I always start with these three numbers. It'd be interesting if anybody knows what these three numbers are. First number is, can you read that number? It's $3.4 trillion. That turns out to be the amount of money that we spend in the United States currently every year on health-related services. $3.4 trillion, not $340 billion, $3.4 trillion. So it is an enormous industry. And certainly when you have something that size, covering it in any detail in 40 minutes is going to be tough. The second number is the percent of the GDP. We're up to about 18% of the GDP. That number goes up every year. So of all the sum of all the goods and services that we deliver in the United States, about 18% of it goes to the delivery of health services. The last number is a somewhat controversial number, but is usually where the World Health Organization ranks the quality of the healthcare system in the United States, 37th in the world, which is far from where you may think it would be. So this little graphic, it illustrates how much money we spend compared to a lot of industrialized nations. This is a little bit old. Now that number went from $8,700 or whatever to almost $9,000 per individual per year. Compared to the rest of these industrialized nations, it's 2.5 times the average of the rest of the world. That's what we spend in this country. Unfortunately, the trend continues to go up. We've diverged a long time ago, somewhere around 1980, oddly enough. And so our healthcare expenditure curve has diverged and goes up every single year. So this is a graphic that's a few years old now, but you can see where we stand compared to some other advanced nations. We also don't rank particularly high. So this is 11 nations on the list, World Health Organization ranking, and we're last on this list for a lot of reasons. Access and cost, of course, at the top of the list. We also probably spend a whole lot of our healthcare resources are spent on waste. Lots of researchers have examined this, and this sort of shape of where the money goes is fairly common, and it goes in a lot of different directions. So we think we waste a lot of the money we spend on healthcare, about 30%. So you can argue with some of the ranking methodology, especially by the World Health Organization, but this is an interesting graphic that is hard to deny, is that the average, we live on average about 78 and a half years or so, 79 years. And our healthcare expenditures are graphed on the x-axis, and compared to other nations in the world, we don't live as long, we spend a whole lot more money. That's a somewhat frightening graph. Now, I will be first to say that healthcare does not necessarily the main determinant of longevity. We know there are many other things that determine longevity, but not just healthcare. But this is an interesting graphic. I think one of the good things about healthcare in America, it employs a lot of people. This graphic shows through the Great Recession and healthcare employment continued to rise where a lot of other areas have failed. So, and I think this is an interesting and potentially positive thing about American healthcare. It may not be the highest ranked. We may not live as long, and it costs a whole lot, but it doesn't employ a whole lot of people. Probably around 5 million people are employed in the healthcare sector now, and it goes up every year. Also have to kind of address the nomenclature that we use and the scope of what we call biomedical informatics. Now, biomedical informatics is different than bioinformatics, so it's confusing, but biomedical informatics is an umbrella term that I think is constructive to sort of look at the things that fall under that category, because this is where the data comes from. At the lowest level is down at the molecular level, is where obviously lots of data comes from. And that whole field is sometimes called Chemo Informatics. And so we're looking at new drugs, especially small molecules, and gathering a lot of data on that. And so that's kind of starts at the very small. The next step up is what's called bioinformatics, again, distinctive from biomedical informatics, and it includes things like genomics and other omics like proteomics, and obviously that generates a huge amount of data into itself. Step up from that is called imaging informatics. Largely that's around pathology and radiology imaging. Interestingly, that's been one of the success areas for informatics, is to look at those types of data and how we analyze those. Step above that is what we call clinical informatics, or sometimes it's called medical informatics. It generates a huge amount of data on its own, and it's basically the data that is captured during the administration of care between a provider and an individual client or patient. So that transactional data, that whole field is called clinical or medical informatics. Step above that is population health informatics, which is distinctive from the next step, which is public health informatics. Population health informatics is a term that's been co-opted by the health care industry to describe, and I'll talk about this later on a little bit more, describe the field of using data to improve the health of populations, usually populations as defined by healthcare systems, not by the state or county or nation. Public health informatics is kind of what it sounds like. It's the whole country, and we're talking about the health of the individuals in a state or a region or a country. So those are sort of the broad categories of informatics, and there's huge amounts of data from all of these things. And when we talk about big data, you almost have to say, what part are you talking about? So why big data, or data in healthcare? There's been a number of drivers. I list population health as one of the first ones because this has coincided with the Accountable Care Act, and started more or less in 2008, and has generated a huge amount of, in healthcare, a huge amount of energy and investment into new delivery models. And I'll talk about that in just a little bit, but population health is certainly one of the main drivers. Another driver, and I think you've had some presentations here today, is precision medicine. Interestingly, even though there are some federal initiatives, this is being largely driven by the private sector, unlike population health, which is mostly being driven by the public sector or government sector. Obviously, when we're talking about big data, we're talking about the ability to analyze big data, and you guys know this better than I do, but high performance computing, advanced data storage, and this is important because we're talking about astronomical amounts of data from the healthcare industry, and obviously advanced machine learning has really spurred this on. And last but far from least is the data availability, and since about 2008 there has been a huge move from federal agencies to make the data transparent. In other words, that you can get the data, whereas before it was cloistered and only researchers could get at it who've gone through a lot of hoops. All right, what is population health? It's also very much connected to the idea of value-based payment or value-based reimbursement. So fee-for-service medicine is still largely what American healthcare is about. You have a service, whether you see a physician or whether you get a test or you get an operation, and you pay a fee. Oftentimes we don't personally pay the fee, the insurance company pays the fee for us, we may have a copay. Population health is changing that equation, or value-based delivery is changing that equation. Instead of being paid for the service, more and more moving toward being paid for the outcome, the results of the service. And so value-based payment and population health are terms that often are used interchangeably. The value-based payment systems largely focus around what is called the triple aim in healthcare. and which is illustrated by this little graphic, which is improve the health of a population, lower the per capita cost, and improve the experience of care. Without the change in the payment models towards the value-based payment models, none of this would move away from fee-for-service medicine. And so from government agencies, largely, not entirely, but largely have driven this change in reimbursement towards a value-based model, based upon the context I just gave you about the expense of health care in America. So, one of the things about value-based payment, you have to understand the Pareto Principle in populations, that a small percentage of individuals take up the largest percentage of healthcare dollar. I've been in the situation where I actually had access to very large healthcare data sets, and this is exactly right. The number is actually more like in the Medicare population around 77-23 is not quite 80-20, but in fact that is true. So understanding that Pareto Principle, if you're going to affect the per capita cost of care, you're mostly not focused on 100% of the people, you're focused on a fairly small percentage, 20% more or less. Another success factor in value-based payment delivery, if you're going to make money off of those delivery models, is that you understand predictive modeling. So why do you need to understand predictive modeling? You need to be able to predict who the people are in that high-cost stratum, right? Now, you say, well, you just look how much money you spent, but then, of course, you always have that problem of regression to the mean. The patients from last year are almost certainly not going to be the same patients this year at the top of that stratus. So the predictive modeling is a very important part in value-based care delivery success. From predictive modeling, you stratify the risk, so you know which one you think are going to be the ones that use the most resources. And then ultimately, you have to be able to take care of the individuals in those top risk strata. So that's the build special programs around that. So in essence, this is how value-based reimbursement works. Without the data, without the large amounts of data, you can't successfully do predictive modeling, risk stratification, and program design. Another big driver is precision medicine. I know there's some people here today who's from precision medicine companies. And it's really an emerging approach to disease treatment that's around specializing the intervention for the individual versus the average, and it largely has been around genomics up to this time, but in fact the concept is much larger than just genomics. And mostly really at this particular time is around what's called pharmacogenomics. So in other words, there are certain medications that work better for someone with certain genetics than other people, and largely this has been around people with malignancies. If you think about it, it's really very much similar to the concept of population stratification. In fact, this is another way of population stratification by using sort of a different approach from bottom up instead of a top down, and so that you can find people who will respond differently or need special types of intervention. There is federal initiatives around precision medicine. It's certainly generated a lot of excitement, one of which is called Of All of Us, a research program sponsored by the NIH. It's trying to enroll 1 million people. Anybody in the room is interested, you can go to the website and potentially enroll as one of the 1 million volunteers who are going to contribute their healthcare data. Lots of opportunities and all of us research opportunities, and I won't spend a whole lot of time going through these things, but obviously develop new ways of measuring and assessing risk, also with the goal of identifying people who will respond differently to different interventions, especially around pharmacogenomics, new biologic markers of diseases, mobile health, and new disease classifications potentially. Precision medicine, again, has attracted a lot of private research investment. Here's just a casual group of companies I've found on the internet. I highlight Envision Genomics. Actually, a person I used to work for is now, who was in a population health company, now in fact is the CEO of Envision Genomics. So there's a bunch of investment dollars going into these companies. So there's a lot of ways that big data analysis can disrupt healthcare. By disrupt, we mean change some sort of the fundamental direction. Now here's just a few of the ones I think it might apply to. One is radiology and pathology images. Image analysis, interestingly, lend themselves to big data approaches. And I actually have a couple of cases I'll share with you in a little bit. One of the caveats of images analysis is that the gold standard is almost universally the human analysis of those images, and so the artificial intelligence algorithms try to match the best of the human analysis. Another potential disruptive influence is much improved predictive modeling. The best commercial programs that we have had in up until fairly recently, the absolute best that these predictive models will do is predicting healthcare expenditures a year or more in advance. We had an R-square of about 0.27. Really bad, like remarkably bad. And so I think there's a lot of potential opportunity for big data analysis to change that. Improve clinical diagnosis. So diagnostic systems, interestingly, there's been AI systems in healthcare for back into the early 70s. Obviously, the methodology for artificial intelligence has dramatically changed, and so and there's business models around that. Many of you are familiar with the IBM Watson system. And of course, ultimately improve treatments, especially around malignancies, but other diseases as well. I'd like to spend a little bit of time talking about data sources. You know, many people who have not been in healthcare may not realize the breadth of the data sources. So I'm going to talk a little bit about electronic health records, the data that comes from those sources, healthcare administrative data, sometimes called claims data is another big source, pharmacy data, social media, wearable devices, obviously genomic data, as well as clinical trials and research. So what are electronic health records and what do they contain? Probably most of you in this room have had any healthcare exposure or got an electronic health record on you personally. They've been a major federal incentive program for the adoption of electronic health records. Well over 95% of all hospitals in America now use them. I would say the number of physician practices is probably 85 or greater percent. So it has become the standard really just in the past probably 8 years. And it went from hospital adoption of somewhere less than 20% to greater than 95%. So almost everybody who has any kind of health record now has an electronic version of that. So what's in it? Obviously almost everything. Demographics, clinical notes, problem lists of all kinds, mostly in coded nomenclature, orders and results of labs, radiology, other diagnostics, medication lists, physiologic data, blood pressure, weight, various measurements that physicians take. And there's also, these same systems have a lot of clinical decision support tools with the idea of helping providers make better decisions. So I have a series of really just screen captures, and I'm showing these to you, not for you to take anything particularly concrete away from it, but really to illustrate the kind of enormous complexity of these systems. And when you see them, you will sort of get a sense of, oh my God, what have we done here? This is called a history of a predictive illness. I'm not going to march through any of this. You can see it's a very busy screen, lots of sections on one side. It's got a little graphics in here. This is a sort of summary sheet that you will see in electronic health records. It's, it's got a summary of tons of data in there. A little bit blurred on this screen, but you got labs and charts and flow sheets and demographics and on and on. And so these data elements are displayed in ways that potentially you can digest more easily. This is a fairly common representation of a progress note. Progress notes is what it sounds like. It's a note of your progress. Many of them are structured in a way where you enter data into boxes and have pick lists of information that drop down so you can fill it out more quickly. This is another type of progress note. It's even more structured. So all these little boxes, some of them bring in data from other systems so that you can see it. Some of it you enter. You can see that this is a particularly busy one with lots of buttons you push to make stuff show up in there. Orders and order statuses. So here's a bunch of orders. This would be from a hospital. Same thing in an ambulatory space. So you can see the amount of data that's captured there. This is a screen where physicians can enter orders into the computers, and so that someone will follow them, whether it's to deliver a medication or order tests and that sort of thing. So I guess the reason I show this is to show you the complexity of the data that are in these systems is almost beyond comprehension. And I don't mean that in a good way. I mean that these are very counterintuitive tools. They don't lend themselves to user friendliness. And whenever that's the case, then you oftentimes have unhappy users of the technology, and unhappy users frequently don't use the technology very well or correctly. So I'm switching gears just a little bit to some examples of big data contributions to healthcare sciences. These are all very recent publications. It turns out the Journal of American Medical Association is one of the primary places these things show up. There's some other journals, but JAMA for some reason is really taking a real interest in big data analysis and artificial intelligence, and so a lot of studies are published in that journal. One of the more interesting ones, I've got 2 or 3 here, have to do with images, and this was detecting diabetic retinopathy. Now, people with diabetes are prone to diseases of the eye, diseases of the retina, and they can actually go blind, so it's an important distinction to make. Again, any of these image analysis are the gold standard almost by definition is still human analysis. So when these studies are done, basically the point is to get the machine up to perform as well as a human, because by definition, they're perfect. That's the gold standard. So this retinopathy study used a technique called deep convolutional neural networks. Probably half of you guys in here do that for a living, I don't know. And it was trained on a retrospective data set of 128,175 retinal images. There's actually 2 different types, 2 different data sets, and they were scored based on a grading system that human devised for diabetic retinopathy, and from 3 to 7, were graded 3 to 7 times for each one of the images. And so for one of the image sets, the sensitivity for the deep convolutional neural network was 97.5%, and specificity is 93.4%. And a second set, the sensitivity is 96.1%, and specificity is 93.9%. And an important part of this is each one of these images were graded multiple times by humans. And so you say, well, what's the advantage if humans are going to do it anyway? It's really, if you think of them as a screening tool for diabetic retinopathy in places that are underserved or don't have highly specialized individuals to grade these things. And so that's an astonishing result, honestly, that you have is probably better than most human graders result from this type of technology, and that now this could potentially be, and actually is being, put into commercially available systems for diabetic retinopathy detection. Another example is detecting breast cancer in lymph nodes. For individuals with breast cancer, one of the main issues that the patient and the providers face is, has it spread outside the confines of the breast? Is it in lymph nodes? And if it's in lymph nodes, it changes your intervention. There's evidence that the tumor has already spread. This study was published in JAMA, Diagnostic Assessment of Deep Learning Algorithms for Detection of Lymph Node Metastasis in Women with Breast Cancer. And it was a research challenge on Kaggle. Probably most of you are familiar with Kaggle, so they had these images. A research challenge, that particular one, which is CAMEL, Cameleon, perhaps, Cameleon, 16. They now have a Cameleon 17, so a new challenge. But they had a fairly small training data set of somewhere around 160 pathology images. And once again, it was enormously successful. The winner of the challenge, really matched the best of humans, especially in an experiment where it was time limited. You think about, if you have hours to look at an image, and you probably do a better job than if you have the typical working pathologist of 30 minutes or whatever it would be. And so when you compared to a pathologist that's doing it in a time-limited fashion, like a real-world sense, it was incredibly successful. And that in this case, in the area under the curve was 0.96, which is pretty darn incredible that the sensitivity and specificity was that high. That you essentially could use that and maybe in a clinical way. The last example I'll give is cardiovascular risk prediction from electronic health record data, not image data. This was in PLOS 1, Can Machine Learning Improve Cardiovascular Risk Prediction Using Routine Clinical Data? This was done in UK as a prospective cohort study using routine clinical data in 378,256 patients. UK is a little bit different. They've been collecting electronic data for a long time so they can actually do longitudinal tracking. They looked at 4 different machine learning algorithms. And the idea is that we have used clinical risk scores for years and years, long before computers were particularly involved, and they're used for different purposes, but in this case they compared to the best clinical predictive value of mortality with cardiovascular risk factors, and found that with the best of the learning algorithms improved the risk. And again, this was over a 10-year period of time, the predictive by 7.6%, which again is pretty amazing that you can improve an algorithm been used for many years, and with these algorithms, these fancy machine learning algorithms, it can improve that prediction of mortality by 7.6%. So a few interesting use cases that have been published. There's more and more of them being published in the mainstream medical literature, and I suspect we'll continue to see more and more of these things as time goes on. So I'm going to talk a little bit about where the data is and maybe how you can even get some of it. One, it's mostly not available on the internet, and so there are people who first place you go is the internet and get it. They're almost universally behind some sort of wall to where you have to get permission to get to that data. And then the key term is almost universally, and that there's more and more that can be gotten, that is on the internet. But when I say mostly not on the internet, I'm talking about in source systems. In other words, they've not been extracted at all. It's not in a data set, but in fact lives in source systems, because most of this data, especially in healthcare, was not collected for the purpose of research. It's collected for the purpose of the business interactions with clients. And I mean that in the broadest sense, business being clinical interaction with patients. And so it's transactional data. And so these source systems, like in electronic health records, are in relational databases, which are oftentimes poorly documented, and they change over time, and it's really a major effort to get that data out of these source systems and sort of into a usable format. And many people in the field of healthcare data analytics find they spend at least 80% of their time trying to get the data out of the source system, and that's where most of this data still lives, is in the source systems. There's private paid claims data. You can get this anonymized data through a couple vendors, several vendors. IBM now owns what used to be called Truven Health, and some of you may have used MarketScan data. They sell this data. Again, it's anonymized. They have a huge amount of private health claims data that researchers can use, assuming they have the resources to buy it or rent it, is really what you do. And then another company is called Fair Health that also has insurance claims data. Some healthcare organizations can actually get identified claims data by requesting it from CMS. So CMS, if you go through the proper hoops, you can actually get your own patient's healthcare data to analyze. I'll mention a little bit about data enclaves. Now, most of you are probably familiar with the concept of Hipaa. Hipaa is really around insurance claims protection, and the Hipaa laws are pretty strict about using identified data, and organizations that have patient-identified data are severely restricted in the research case for that, especially for researchers outside of employment of those organizations. And even de-identified data now is considered at risk, because the data scientists are able to trace the identities of individuals even when the identifiers are missing from the data. And so the concept of data enclaves is more and more being used by organizations and vendors to where you don't actually get the data. You go to this data enclave and you use SAS or R or something, and you analyze the data in place. you don't receive this data. I suspect in the next 5 or so years this will be the norm and not the exception, and so that you will not be able to get this data because that data is, one, it's oftentimes proprietary, and two, susceptible to misuse. So CMS is already offering a lot of their data sets only through data enclaves, and you have to get permission to go there, but you can't actually get the data out. You can run SAS code or R code or something in there to get it. A fair number of large health systems are instituting these data, clinical data warehouses, and this is where they take all this data out of these source systems and standardize it in a way for researchers to be used sometimes collectively across a few different health systems, or maybe just that health system, because if you think about it, it is a competitive tool that they can in fact use. So they're not particularly anxious to share it, but they feel they can in fact use it. So they're called clinical data warehouses. You also will hear the term data lakes now, which is really another version of clinical data warehouses, where you take a whole bunch of different data sources and stick them into these enormous databases. I'm not going to go into any detail on this, but CMS healthcare claims can, you can find out information from some of these links. They will be in the file if you're interested. You can follow these links to get some more information about healthcare claims and how to analyze it and what they are. And when I talk about healthcare claims, again, this is administrative data for the purposes of billing. This is kind of what it would look like if you had a file, except that they would go on many, many columns. It's some rows and rows of records and many columns of data, and oftentimes it's very confusing what's all in those data sets. So CMS actually has several different types of data files that they offer. One is called public use files, PUF files. Public use files you actually can download from the internet. You can go to CMS, find a file, download it. Some of them are very interesting. For example, patient protection is a big deal in any of these healthcare files. Provider protection, not so much. Matter of fact, you could go today and download a public use file with all the Medicare charges for all the physicians in the country, including me, by name. So Dale B. Green, and they have my NPI number. And you can see all the Medicare charges, the amount of money that Medicare paid me for all the patients I saw for the years that these files are available. Limited data sets, or LDS data sets, have some identifiers in it, and so they're a little bit more restricted, but the most restricted of the files is what's called the research identifiable files, or the RIF files. Now, they don't actually contain real patient identifiers. They have made up identifiers so that you can track individuals, but these RIF files do have identifiable information in them, and so you have to go through IRB and you have to do all the things you need to get these kind of research identifiable files. Again, Medicare more and more is putting these in data enclaves. They don't even want to share them with you at all. You have to go through these data enclaves. The organization is at the the School of Public Health at the University of Minnesota. It's called ResDec, and you can follow that link and they'll tell you all about those files. There are some clinical study data available, and there's a couple of links here. The clinical study data request website, one at Yale University called the Open Data Project, YODA, supporting open access research and source. So these have some clinical study data. Lots of websites, government websites, data.cms.gov, CDC has public health data, HRSA has data around underserved areas, and on and on. So lots and lots of potential data sources if you're interested in that. All right, part of my talk is supposed to be about the perils of big data analysis. Some of these you already know, garbage in, garbage out. And this is particularly true, I think, for most healthcare data, because most healthcare data, you have to remember, is secondary data. It's not primary data. All this data was collected for reasons not that you're interested in it. Claims data in particular, the claims data was generated for the purpose of paying claims, not for the purpose of identifying disease states or anything, but the purpose of paying claims. Obviously, Hipaa is always an issue. In fact, can limit data access even when this doesn't apply, because everybody's afraid of Hipaa. They don't understand Hipaa. And so this is one of the rate limiting steps. Again, most is secondary data with rare exceptions. There is significant amount of bias in these data sets and that is not random, and obviously. And I'll give you an example of bias. And so as a physician who sees patients, you have to submit a charge, and you submit a charge with what's called a CPT code. And then you have to document why you're doing the procedure that you just did. And you do that with coded data sets now in what's called ICD-10 codes. And so the incentive of the doc right there, one, I'm going to get paid with CPT code. And oh, by the way, I got to pick some diagnosis codes to support my CPT code. And you can imagine the amount of mental effort that might go into that, which is almost none. So I'll pick the first one on the list, or I can only remember one, or I'll use the same one all the time because nobody ever questions me. So whenever you look at administrative data, claims data, and it's particularly around disease diagnosis, you have to take that with an enormous grain of salt and think about where those codes came from and how they got into the data, the source of the data. Now, interestingly, value-based medicine probably is changing that more towards the good. The problem is that most of the organizations that you would get data from, they don't really participate or have not participated in value-based medicine. And so you don't even know which ones are which. The ones that do a good job and the ones that do a bad job. The data all looks the same to you. Huge amounts of data in healthcare stored in text. Now, there's a lot of effort around natural language processing. Maybe some of you have been involved in that. But we are so far from that being a successful way to analyze data, I can't tell you. And I think healthcare may be a little bit even harder than some. I don't know if you're familiar with the term argot. Argot is sort of like a professional language that you have inside of professions like plumbing or something. Well, medicine has their own argot. Text data, you can put anything you want into your text data because it's text. And you can read it and maybe understand it. But it's going to be a real challenge, I think, for researchers to extract a whole lot of research-type information around that. The problem of context. So across the healthcare continuum, context changes. Whether you're in a hospital or whether you're in an outpatient environment, it's a simple context. But maybe you're acutely ill. That's one context. Maybe you're there for a wellness visit in your doctor's office. That's another context. And so the context of the data collected, in a simple example, would be a blood sugar. Most of us understand blood sugar, and say a blood sugar with a value, the metadata that goes along with the blood sugar. Well, when was that blood sugar collected? Was it a fasting value? Was it not a fasting value? Now, well, that's one thing. Well, were you ill or were you not ill? That's another context. Was it even blood? Maybe it was urine or spinal fluid or pleural fluid. Those are other contexts. So the context of that value can be enormously misleading unless you have all the metadata around it and it is correct. And so that's one of I think the biggest problems with healthcare data is the problem of context. Obviously, any of these AI systems that you talk about is really black box inference, and of course you can make that same argument for much of statistics, but the algorithms are now so complex, it's essentially impossible to determine how some of these artificial intelligence systems derive their answers. And what makes it even worse, if my understanding is correct, is that if you run them through these convoluted neural networks more than once, they'll figure it out different ways the second time. So it's interesting how it's essentially impossible to understand how some of these things work. Obviously, data silos is still the rule versus the exception, and there's data silos all over. I bet in this very city you probably have multiple health systems that compete against one another who are guarding their data from their competitors down the street. All right, there's a lot of characteristics of data quality you have to consider as well as accuracy, accessibility, comprehensiveness, and this is particularly true with a lot of healthcare data. It doesn't cover the entire story. Consistency of meaning, abbreviations are still a serious problem, and actually the same physician using the same abbreviation will sometimes have different meanings based upon the context. Even though the same physician using the same abbreviation, it's just a different meaning because of the context. Currency, how current it is, obviously. The definition of many of these things, the granularity, precision. This is particularly true, and once upon a time I did a little project with blood pressures. And amazingly, looking at a bunch of primary care practices, how often somebody's blood pressure was exactly divisible by 10. Turns out that's not physiologically possible, but it was just a shortcut way of doing it. Exactly, it's either 120 or 130, 140 over 60, 70, 80. And so basically you don't really even have numeric data, you have categorical data at that point. And the timeliness. I have to at least mention these concepts, and they're referred to variously as ontologies, taxonomies, and nomenclature. Healthcare is full of these things. There's probably at least 50 of them. A couple of the more common ones is CPT codes, current procedural terminology, and these are codes used for billing purposes, and it says I did this. And that includes what's called evaluation and management, but also can include heart surgery. ICD-10 codes, or International Classification of Disease codes, are used for documenting disease states. Again, oftentimes they're in pick lists. You pick the first one or the one you remember. SNOMED CT is sort of the Mac Daddy of all these standard nomenclatures, and actually has crosswalks to many of them. The caveats I've mentioned somewhat already, that humans enter these codes, they're not magic. In many situations, it's not, in fact, a certified coder at all. In fact, it's the actual provider themselves, who circle something on a piece of paper or enter into a computer, and they usually in pick lists. Clinical concepts themselves are often inexact. In fact, fitting one of the codes, despite the fact there's tens of thousands of these codes, you'll find that none of them work. They all come across as somewhat arbitrary and don't really fit this situation. I would say one physician out of maybe 100 really has an in-depth understanding of these coding schemes. Matter of fact, I would bet that more than 50% of them won't even know what an ICD-10 code is. I mean, it's really that bad. Few incentives for correct and complete coding, although value-based delivery models are more and more moving in that direction. All right. One more caveat. Interestingly, I ran across a little bit about IBM Watson. I don't know if there's anybody from IBM Watson here today. And this Watson is, IBM's made a big move into the healthcare space with this artificial intelligence engine Watson, and they have promoted it tremendously. You go to conferences and there they are, they have a big booth, they have a whole bunch of people there. And this article, which I read, was in New York Times in 2015, IBM creates Watson Health to analyze medical data. They were going to solve the riddle of cancer. Well, fast forward, and I saw this, which just came out. IBM Watson gave unsafe recommendations for treating cancer. This was from July 26. And so the message really is, this is a quote at the bottom. This product is a piece of blank, one doctor at Jupiter Hospital in Florida told IBM executive. So, these are very, very sophisticated technologies. And we as medical professionals largely, and you as researchers and scientists and data science, I cannot overstress how important it is that make sure that your stuff works in many different contexts. And overselling it or hyping it does the profession no good at all. Because this kind of message here, and I actually believe Watson is a very useful tool that's pushing healthcare forward, but it gets colored by this brush and it does an enormous amount of damage. And so all you have to do is this product is a piece of, and next thing you know, that's the way it is in the heads of the users. The last slide I have is this friend of mine, Jason Burke, is at UNC Healthcare. He's really sort of a brilliant, interesting guy. He calls it the Sand-Mandela problem. I'm not sure if that's pronounced Mandela or Mandela, so I'm going to call it Mandela. And so you've seen these things where, these Tibetan monks, they have these sand paintings, and they're very intricate. They can take weeks or months to produce these beautiful sand paintings. And there's a whole group of them working on them, and it's enormously beautiful and intricate. And and what do they do when they're done? They sweep it away. They take a broom and sweep it away. And honestly, to a fairly significant degree, at this point in time, these enormously complex and sometimes beautiful data science projects are treated just that way. You show it to the people who ask you to do it, and they say, that's nice, and that's the end of it. And why this matters is that you, as data scientists, you have to make that not happen. You have to engage the stakeholders, oftentimes in where they're from. They don't understand your artificial intelligence algorithms. They're not particularly interested in the artificial intelligence algorithms. And ultimately, it's oftentimes back to the story that you tell and the relationships that you build. And so these soft skills, I think, are extremely beneficial for people in this field, and I would encourage that. So I think I went over a couple minutes. I'm sorry. I do have a little selected bibliography, I think, about data science and healthcare, if anyone's interested. And I will stop here and see if there's anybody has questions or comments. I'd be particularly interested in comments you may have. Yes, sir.
With the examination of retina that you brought up earlier, and getting to a point where the machine was close to one of the better humans at identifying the problem there, could an approach be to continue to take images over a course of time and then get better than a human? So to predict, the human missed something in these early images that the machine can now identify, knowing that eventually that led to the problem.
Yeah, that would be a fascinating, I've not heard of those types of studies, but a longitudinal kind of clinical trial. Yeah, I think you're exactly right. That would be a really interesting study to do, I think. I haven't heard that those studies have been done. Probably not, because it's not been really long enough for that, but that would be a nice grant proposal, I think. Yes, sir.
What's your general sense about the perception in the healthcare community about things like IBM Watson and AI? Is it like stick with it, it'll get better over time, you know, right now, or are you kind of like, okay, this is...
You know, I think the general healthcare community is largely just completely ignorant of it. They don't, it's a very closed world that most providers are in, and so you see the world through this lens, and that's the only lens that you see it through. I don't think, as long as I mean, obviously in research communities there's more interest in this sort of thing, but you also, unfortunately, much as I hate to admit it, one of the challenges it would have by promoting it is a competitive issue. Either you're stealing my patients kind of thing. So it's going to happen. There's no question in my mind, but how it gets there. You would think, but it's been, physicians are a very provincial bunch and oftentimes suspicious. Yes, sir.
So medicine has long used all kinds of scores like Hipaa score, Apache, and so on, and physicians got used to it. But they were relatively easy to understand because you had a measurement and added them up and all this kind of thing. How do you see physicians will get used to artificial neural networks, and you mentioned some of the problems. Do you think physicians will get used to it, or will this become something like your Mandela problem?
Yeah, you know, I think in specialties where cardiology is a pretty good example, and obviously neonatology with APGAR scores, where it becomes part of the culture, then it's used all the time, probably to the excess of what it should be. But, you know, it's not impossible to get these things into the general use. Again, I sort of think it's back to that, how you position it, the repetition of it, and you know, and I think professional societies, when they adopt these things, this is the way to do it. Oftentimes, it drives it to much more than any individual could. So, professional societies is probably the way to get your foot in the door on some of these things. Yes, sir.
So I have a question that's based in part on some of the slides you had up when you were showing the entry systems for these medical records, and partly is related to some personal experience my family has being in hospitals. Why do those tools have no data visualization?
Yeah, that's a pretty good question. I think one easy answer to that is that the idea of how your group of patients are doing is fairly novel. Healthcare is traditionally a transactional model, one patient at a time, and that you see the world one patient at a time. Now, trend data, there's been sort of, trend data like blood tests and that sort of thing for individuals, but it's very unusual for physicians to have access to population-based data, like how am I doing overall. So I think the absence of, an incentive to do it that way, because unfortunately, even now, largely doing a not particularly bad job actually is a way to increase service volume. If you do a terrible bad job, then you're going to have some legal issues or get a bad reputation. But like misuse of resources, like CT scans, or if you today, I don't know how many emergency departments there are in this community. If you went in complaining of acute chest pain and shortness of breath, you will get a CT scan. Then if an hour later you went down, after you got out, you went to the other hospital, you'd get another CT scan in all likelihood. I'll bet you most of those hospitals just repeat that scan. Despite the fact you may have had multiple of them in that day. It's potentially a life-threatening problem with a blood clot to the lung. The liability issues, perceived liability issues are significant. And maybe they just missed it at the other place. Plus, we don't have a data sharing. Now, I don't really know that about Grand Rapids, but we don't really have an easy methodology to actually share that data. So I don't know, long answer to probably not even the one you're looking for, but I think data visualization, especially in population health, would be enormously valuable. All right, well, thank you very much.